Hello, everyone. Welcome again to our Catching the MDM Wave Data Review Interactive Q&A webinar. My name is Ashley Decoto, and I'm a specialist with our Provider Outreach and Education team. On the call with me today is my friend and colleague, Leanne Foster, who will be helping out with the chat. This webinar is part 2 of our 2-part series on the data element of medical decision-making for evaluation and management services. Yesterday, Leanne held the part 1 webinar, which provided a more comprehensive overview on the data element. If you were not able to attend her session yesterday, that recording will be available within the next week or so in the Training Center of our website and on our YouTube channel. We will also have a recording of this session available in the Training Center on our website, and Leanne will be adding a link for that Training Center to the chat. It will be available on our website for the next 60 to 90 days, barring any technical issues with the recording. And you can access this without having to access YouTube, as we do recognize that not everyone is able to access YouTube from work. The recording will also be available on our YouTube channel, and it will stay there as long as this information remains relevant and current. Also in our Training Center, you can find a copy of today's presentation. So if you haven't already grabbed that, it is still available for download in case you'd like to have the presentation to follow along or to take notes, though it's not required. We are taking questions through the chat today, which again, Leanne will be monitoring. I will check in with Leanne at the end of the presentation, time permitting, for any unanswered questions in the chat. We did have quite a few questions that were pre-submitted with registration, and I will be answering those that relate to the data element of MDM throughout the presentation today. If we do not get to live chat questions, we will answer those in a follow-up email. All right, for our agenda, we'll start by doing a brief recap from Leanne's part 1 webinar yesterday. After that part 1 recap, most of this session will be the interactive Q&A activity. And then lastly, we will be sharing a few resources. This 2-part series, again, is meant to focus specifically on the data element of medical decision-making. While we'll be talking about the data element today, Leanne and I have one additional series scheduled next month for the risk element. We did have a handful of questions regarding the problem and risk elements of medical decision-making, which we're not covering today. Now, registration is open for the risk series on our live events page, and then the recording of the series on the problem element is out on our YouTube channel. We did receive a few pre-submitted questions asking about updates, and I wanted to bring this up right away. At this time, there haven't been any changes to medical decision makings, so we don't really have any new updates to share. Later in the presentation, though, I will review some 2025 CERT errors, but aside from that, there are no additional updates. Okay, let's start with a recap of Leanne's session from yesterday. So when you're choosing your code for most evaluation and management services, you can use either the time spent for that encounter or medical decision-making, or MDM. When using MDM to choose your level of service, you'll need to consider 3 elements. The first element is the number and complexity of problems addressed during the encounter, which Leanne and I talked about in our series last month. The second element of medical decision-making is our main focus for this series, and that's the amount and complexity of data reviewed for the encounter. The third element is the risk of complications and/or morbidity or mortality of patient management, and our series on the risk element, again, will be held next month. Now, most E&M services have 4 levels of service, which are straightforward, low, moderate, and high, or some just have 3 levels where straightforward and low are combined into one code. You'll select your level of service, based on meeting or exceeding the requirements of that level for 2 out of the 3 elements. So for example, if you have a moderate level of problem, a moderate level of risk, and low data, you can select a moderate level of service because you met that for 2 of the elements. Another thing that becomes really important in medical decision making is using CPT definitions for each element. These are outlined in the CPT book and also in a CPT resource that Leanne will be putting in the chat. There are definitions for the types of problems, the components of the data element, and for the examples of risk. So here let's take a little closer look at what the data element of medical decision making includes. The CPT book defines data as medical records, tests, and/or other information that must be obtained, ordered, reviewed, and analyzed for the encounter. So the data element accounts for information that the practitioner must gather and use in determining the treatment plan. Each level of data reflects an increasing level of review or analysis. So data is divided into 3 categories, as we have shown here on this slide. Category 1 includes tests, documents, and independent historians. Category 2 is independent interpretations, and category 3 is discussion of management or test interpretation. Each level requires meeting the requirements for a certain number of categories, as shown in the MDM table. Now, you can find the MDM table either in the CPT book, if you have that, or in that link that Leanne added to the chat on the last slide, in case you maybe don't have access to the CPT book. So if you click on that link, you'll find that MDM chart starting on page 8. So let's look a little bit at each level of data. That MDM chart tells us first that straightforward data does not require any of these 3 categories. Next, low-level data includes only category 1 and category 2, and you must meet the requirements for either one of those 2 categories. Now, note that only for low-level data, independent historian is included in category 2. In the moderate level, independent historian moves to category 1, and we add in a category 3. You must meet the requirements for one of the 3 categories for moderate level data. And then lastly, for high level data, which CPT also calls extensive data, you must meet the requirements for 2 of the 3 categories. Now, when you're counting data in these categories, the biggest thing to keep in mind is not to double count. Meaning, if you're billing separately for anything, you would not count that in your medical decision making. So for example, if you're billing separately for, let's say, an interpretation of an EKG, you would not also count this under the data element. You want to make sure that you're not double dipping, so to speak. So we've included this slide here to show what errors have been found that relate to selecting level of service. 2 of the top CERT errors for office visits we have listed here on this slide. The first error listed here, you may have seen before, which is the error for documentation supporting a lower level of E&M. So make sure that your documentation supports the level of service billed. Remember, for the data element, you won't count anything that you've separately reported. So if you bill for the professional component of a test, you wouldn't also count that under the data element. Now, the second bullet point here, this might come as a surprise to some, which is the error for documentation supporting a higher level of E&M. And the point we want to make by including this here is do not sell yourself short for work that was done. So be sure to reference that chart for medical decision making, and don't miss out on things like discussion of management or gathering information from an independent historian. If it is documented, you don't want to miss out on counting that for your data. We did include 2 links here. The first is to a page on our WPS website with more information on E&M CERT errors. The second link takes you to the CMS website, where you can find a list of CERT reports. The 2025 CERT report was released January 24th of this year, and that's where you'll find these E&M errors. Okay, now we're going to shift gears into our interactive Q&A activity. We've designed this to be kind of a fun way to test your knowledge. We will be launching a poll for each question during this activity. Even if you aren't 100% sure on the correct answer, we'd love for you to participate and just give it your best shot. I'll give you a moment to lock in your answers, and then I'll walk through the correct answer for each question. For those of you who have attended our Q&A activity webinars in the past, I wanted to make note of a slight difference you might notice today. Due to some recent changes with our webinar software, you may need to click an icon with a plus sign. It should be down next to the chat icon towards the lower right-hand corner of your screen. And it would say Show Apps or Show Apps Panel if you hover over it. Once you click that button, it should allow for you to click on Slido, which is the platform we'll be using for the poll questions. Before I launch our first question, we did have some pre-submitted questions asking for resources. This slide has resources for our activity today, and Leanne will also be placing these links in the chat in case you haven't downloaded the presentation. And you're welcome to have these open to help out with the activity. The last resource that's listed here is the CPT page we shared earlier, and one that I find particularly helpful for medical decision making. This is, again, great for anyone who does not have access to a CPT book, where, again, you'll find the MDM chart beginning on page 8. So feel free to open that up to help you with these questions during our activity. All right, so for our first question, there is no right or wrong answer for this one. Let me launch this question. We just want to get a feel for what everyone thinks about the MDM elements and give you all a chance to find the Slido app in WebEx. So this question is, which element of MDM do you personally find the most challenging? You can select problem, B for data, C for risk, or D if maybe you don't know, or if all of them are challenging. I'm going to give it just another minute. I know some are still trying to launch or open up the Slido app. All right, I think most of you have your answers in. It looks like most of you are selecting risk. We've got a few for data and then a few for problem, and the majority, 53%, are selecting risk. So for those of you who did select the data element, we hope that this series will help some with that challenge. For those who selected problem or risk, make sure you watch that recording for the series on the problem element and sign up for that upcoming series on risk, which Leanne and I will be doing next month in August. All right, now we'll really get into it with our first question. Our first question is, give me just a moment to launch that question. So our first question is, if documentation supports a low level of problem, moderate level of data, and low risk, which level of service is appropriate using MDM? Is it A, straightforward, B, low, D, moderate, or D, high? All right, we like to start out a little on the easier side. Most of you have gotten your answers in, it looks like. The answer to this one is B, low. You must meet or exceed the level for 2 elements to select your level of service by MDM. In this scenario, you have met or exceeded 2 elements in the low level. So even though you have moderate data, 2 of your 3 elements, problem and risk, are at a low level. So you would choose the low level code in that scenario. All right, our next question. Next question is, which of the following are part of category 1 for data? And you can select all that apply for these options. Is it A, independent interpretation, B, review of external notes, C, ordering a unique test, or D, discussion of management? We've got just a few still getting their answers in. Okay, the answer for this one is B and C, review of external notes and ordering a unique test. Now keep in mind, something I mentioned earlier, that category 1 changes for moderate and extensive data. So for your low level data, category 1 includes review of external notes from each unique source, review of results from each unique test, and ordering each unique test. For moderate and extensive data, category 1 includes those same items, plus assessment requiring an independent historian moves into category 1. Something that might seem kind of a little tricky, so I wanted to point that out. Another thing to point out with category 1 is the number of items within that category that you must have. So for low data, you must have any combination of 2 items under that category. And for moderate and extensive or high level data, you must have any combination of 3 items in category 1. So what does that mean? Well, to have any combination of 3, you might have 1 review of a unique test, 1 independent historian, and review of 1 external note. Or you could have review of 3 unique tests, or maybe you have 2 unique tests and 1 independent historian. So any combination of 3 would meet that requirement for category 1 under moderate or extensive data, or any combination of 2 in category 1 for low level data. All right, moving on to our next question. Our next question is, a moderate level of data requires meeting how many of the 3 categories? Is it A0, B1, C2, or D3? All right, looks like the good majority of you have your answers in. The answer to this one is B, 1. So to meet a moderate level of data, you must meet the requirements for 1 out of the 3 categories, meaning either category 1, category 2, or category 3. Each level of data in the MDM chart indicates how many of the categories you must meet. So low-level data requires meeting 1 of 2 categories. Moderate level data requires meeting 1 of 3 categories. And extensive data requires meeting 2 of 3 categories. All right, for our next question, on slide 13. So this question is a scenario. We have Dr. Kim, who summarizes the radiologist's findings in her progress note. How can Dr. Kim count this under the data element? Would this be A, an independent interpretation, B, review of a unique test, C, discussion of management, or D, it doesn't count at all under the data element? Okay, the answer for this one is B, review of a unique test. Summarizing a radiologist's findings from an X-ray, for example, is simply a review. If Dr. Kim wanted to count this as an independent interpretation, there would need to be a report of her own findings, kind of similar to what the radiologist might provide. We had a pre-submitted question asking about common errors for data in medical decision-making, and this has been a common issue that we see with documentation as it relates to the data element. If the documentation simply shows a note that the MRI was reviewed, well, this would not be an independent interpretation, and you don't want to count it as such. An independent interpretation would again include a report with that practitioner's findings from the raw data, similar to what the radiologist would do, though it doesn't necessarily need to be at that same level. Another question asked if for independent interpretation, the documentation needs to state the words independent interpretation. And the answer to that is no, but it should clearly be a report of their own findings. Again, not just a review of someone else's findings. We had another question, which asked if the physician orders a test, can they also get credit for independent interpretation? And the answer to that is yes, as long as the interpretation is documented and they're not billing separately for the interpretation. Okay, for our next question, which of the following accurately describes discussion of management under the data element? And you can select all that apply from these options. Is it A, an interactive exchange, B, direct, C, not through intermediaries such as clinical staff, or D, sending chart notes or making notes within progress notes? Give it just another minute here. Okay, the answer for this one is A, B, and C. So when counting discussion of management under the data element, this must include an interactive exchange, and it cannot occur through intermediaries such as clinical staff or trainees. Sending chart notes or written exchanges through the chart notes does not meet this requirement. It does not need to be on the day of the encounter, but you count it only once, and it should be completed in a relatively short period of time, meaning within a day or so. All right. For our next question, for this question, we have a scenario. Dr. Foster provides care in the office for established patient Betty and also bills for the professional component of a chest x-ray. Which of the following is true? Is it A, interpretation of the chest x-ray counts for MDM? B, interpretation of the chest x-ray does not count for MDM? C, Dr. Foster cannot use MDM for an office visit? Or D, Dr. Foster should bill this as a new patient visit? All right, the answer for this one is B. Since Dr. Foster billed for the professional component of the chest x-ray, she cannot count the independent interpretation of that chest x-ray for medical decision-making. It is already accounted for in billing the professional component, so you can't double dip by also counting it under the data element. We had a question about review of tests, which asked, when a provider documents review of a lab, such as a CMP, what information do they need in the documentation to count as a review? So the documentation would just show that a review of the CMP was completed and how it was used in making treatment decisions. There's no specific verbiage that's needed, just clear evidence that the review took place and what that review meant for the patient's care. For example, maybe the labs were normal and the provider documents the review and notes, CMP looks great, so we will continue current medication dosage. Or maybe there were changes based on those results. So the provider notes that the CMP shows maybe low potassium, so they're prescribing a supplement. This shows the review and how the results are used in the treatment plan. Keep in mind that if the provider ordered the CMP, the review of those results is counted in the order, meaning you would not count both for the order and the review. You just count it once. Our next question is another scenario. Dr. Jim and Dr. Sue are both family practice physicians at ABC Medical. Dr. Jim reviews Dr. Sue's notes from Jill's last visit. He may count this in MDM as review of external notes from a unique source. True or false? Okay, got a couple more. There we go. We've got most of the answers are in. So the answer for this one is false. The CPT definition of a unique source includes a physician or other qualified healthcare professional in a distinct group or different specialty or subspecialty or a unique entity. So in our scenario, Dr. Jim and Dr. Sue are the same specialty and the same group, and this review would not count as review of external notes from a unique source. We had a pre-submitted question kind of related to this, which asked, in an outpatient setting, is the only external note from a different specialty? And the answer to that is no. External does include physicians of a different specialty, but it could also be physicians or practitioners who are not in your same group of the same or a different specialty. They do not need to be of a different specialty if they're from an outside group. So if our situation here were a little different, for example, if Dr. Jim, family practice physician at ABC Medical, is reviewing notes from family practice physician Dr. Carroll at XYZ Medical, then Dr. Jim can count that review because Dr. Carroll is not in the same practice. All right, let me get that next question up. So we have another scenario for this question. Patty was inpatient at ABC Hospital from April 2nd through April 12th. Dr. Bob reviews notes from the cardiologist and neurologist. Which of the following is true? Is it A, review of these notes counts as one unique source? B, review of these notes counts as two unique sources? C, Dr. Bob cannot use MDM for an office visit? Or maybe D, Patty could find a new doctor. Okay, so it looks like we're kind of split down the middle on this one. The answer for this one is A. Review of these notes counts as one unique source for the data element. ABC Hospital in this example is one unique entity. So review of notes from that hospital count as one unique source. You would not count this as two reviews, one for the cardiologist notes and one for the neurologist notes. If we look again at the CPT definition for unique source, CPT also says that review of all materials from any unique source counts as one element toward MDM. So Dr. Bob's review of the records from ABC Hospital counts as review of external notes from one unique source. All right, let me get question 18. Here we go, or slide 18. All right, so for this question, we have another scenario. Dr. Corey is a family practice physician at ABC Medical. He reviews the last three progress notes from Sam's outside cardiologist, Dr. J, from XYZ Heart Health. Which of the following is true? Is it A, Dr. Corey can count this as a review from three unique sources? B, Dr. Corey cannot count this because Dr. J works at another practice. C, Dr. Corey can count as a review from one unique source. Or D, should Dr. Corey and Dr. J meet for lunch on Friday to discuss? All right. Most of you have your answers in. 100% of you got that one right. Okay, the answer to this one is C. Dr. Corey counts this as review from one unique source. And this ties back to that CPT definition I mentioned for the last question. All materials from any unique source counts as one element. So all of the records that Dr. Corey gets from Dr. J counts as one review. You would not count one for each visit. We had a pre-submitted question asking if a provider imports results of tests into their note without reviewing them, can these results be counted towards category 1 of data? And the answer to that is no. They would actually need to review those results, and there would need to be documentation of that review and how it was used in making treatment decisions for that encounter. Another question, kind of along those same lines, asked, if a provider documents reviewed outside records, is this enough to give them a data point? Well, if that's all they documented, then no, that would not really be enough. What did they review and how did they use that in their medical decision making? That information would need to be documented. Okay. For our next question, using a translator counts as an independent historian under the data element of MDM. True or false? All right, the answer for this one is false. Translators do not count as an independent historian. A pre-submitted question asked if a family member acting as an interpreter counts, and the answer is no. This would still be considered a translator and would not count as an independent historian. We received another question which asked for the documentation requirements for an independent historian. For this one, CPT requires that an independent historian be an individual who provides history for a patient who is unable to provide a complete or reliable history. So this is not a situation where maybe the wife has tagged along for her husband's visit, a husband who is perfectly capable of providing his own history. Instead, this could be maybe a patient with dementia who's unable to provide a reliable history. You want to make sure the documentation supports why the independent historian is needed. So it might say that Dr. Bob spoke with Patty's daughter because Patty has dementia and was unable to provide a reliable history. Or, though we don't see it too often with Medicare, it could be a minor who is too young to provide the needed history. We had another pre-submitted question on this, which asked, please clarify an age range for children when determining when we can give independent historian by the parent at what age is too old. So there's no published age range for which a child would no longer need a parent as an independent historian. It would be reasonable to expect that a toddler needs the parent to provide history, but a teenager, on the other hand, probably would not. If it is needed, the documentation should show why. For example, my son is 10, and while he's able to share some details with his doctor, she still relies on me to fill in the blanks. But I'd expect by the time he's probably 16 or 17, she won't need me to give his details, and I would not be an independent historian at that stage in his life. So for older children, it would be a good practice to document why they are unable to provide a reliable information. So again, since there's no published age range, make sure the documentation supports the need for an independent historian. All right, let's move along to our next question. So for our next question, for the purpose of data reviewed, which of the following is considered a test? And you can select all that apply from these options. Is it A, pulse oximetry, B, lab test, C, X-ray, or D, EKG? We've got just a couple more getting their answers in. Okay, the answer for this one is B, C, and D. Per the CPT guidelines, tests include imaging, laboratory, psychometric, or physiologic data. We had a pre-submitted question asking what is counted as a unique test. So unique tests are defined by CPT codes. Tests that have overlapping elements are not unique, even if they are identified with distinct CPT codes. And the CPT definition also states that for the purpose of data reviewed and analyzed, pulse oximetry is not considered a test. We had another pre-submitted question, which asked if 3 labs from an outside source count as 1 or 3 points. So it sounds like this question is asking about results from an external source. You would need to consider a few things to answer this question. Did all 3 labs come from the same unique source? Then that counts as 1 under category 1. Keep in mind that CPT says that all materials from a unique source counts as 1 review. If they come from 3 unique sources, then that can count as 3. Also, are these tests that were ordered by your physician or practitioner? If so, that review is included in the order, which would be counted for the visit during which it was ordered. If you're talking about labs that the provider is ordering and reviewing, then each test ordered would count individually, again, when they are ordered, as long as they are separate tests. We had another question about tests, which asked how to determine when tests are unique and/or have overlapping elements. This is a good question. So again, unique tests are defined by the CPT code set, meaning if a test has a CPT code, it can be considered a unique test. However, as I'm guessing the person asking this question knows, if there are overlapping elements, the test would not be considered unique, even if there are distinct CPT codes for those elements. So what does that mean exactly? Well, the example CPT gives is a CBC with differential, which already includes a platelet count and hemoglobin. So ordering a CBC with differential and a standalone platelet count only counts as one unique test because of those overlapping elements. Another example could be ordering a comprehensive metabolic panel, or CMP, and a basic metabolic panel, or BMP. Now, clinically, ordering both of these on the exact same day wouldn't typically happen, but if for some reason it does, if for some reason both are ordered, perhaps because of a computerized order template, or maybe a change in the patient's condition later in the day, they still represent overlapping elements. The BMP's measurements are entirely included within the CMP. So if you look at the CPT code descriptions for both panels, all measurements in the BMP are also included in a CMP. Because those measurements overlap, you can only count this as one unique test ordered for your data in category 1. Okay, for our next question. So for this question, tests ordered are counted twice for data, once for the order and once for the review. True or false? All right, I saw a few of you change from true to false, and for those that did, awesome. The answer here is false. Again, when your provider orders a test, you count that test in the encounter during which it was ordered. Tests that are ordered outside of an encounter are counted in the encounter during which the results are reviewed, but you only count it once. It is presumed that if a practitioner has ordered a test, they will review the results. So the review is included in the order. The only kind of caveat to that is for a series of recurring tests. In the case of a recurring order, each new result may be counted in the encounter in which it is analyzed. For example, an encounter that includes an order for monthly blood glucose test would count for one element, which includes the order and review. Additional future results, if reviewed in subsequent encounters, may be counted as a single test in that subsequent encounter. We did have a pre-submitted question on this, which asked, could you clarify how the ordering and review of recurring labs are counted in the office setting? And they gave the example of routine HbA1c monitoring. So if you order monthly tests in, let's say, today's encounter, you count that order and the first review as one in today's encounter. And if they come back next month, the review done next month is already accounted for. You don't want to count it twice. Any subsequent reviews can be counted for in the encounter during which the review is done. So next month, we don't count because that first review is already accounted for by the order we counted today. But maybe your practitioner sees them again in October, and then again in December, and reviews the monthly results in each of those encounters. You would count one test review in the October encounter and one test review in the December encounter. Another question we had on test asked how to count point of care tests. These could be counted as tests ordered and reviewed, so long as they have their own CPT code and the documentation demonstrates that the review was completed and used in medical decision making. For example, if your practitioner has ordered a results-only test, like a rapid strep test, this counts as one element for your data in category 1. Remember, that includes the order and the review. You would not count once for the order and then again for the review. Just count the once. All right, we have just a couple questions left. All right, for our next question, we have a scenario. During Sally's visit with Dr. Joe, she requests an MRI due to her back pain from lifting heavy boxes. Dr. Joe does not order the MRI. He explains to Sally why an MRI is not needed to treat her pain and documents the discussion. Which of the following is true? Is it A, Dr. Joe cannot count this under the data element? B, Dr. Joe can count this under data as test ordered? C, this is automatically high level of data reviewed? Or D, maybe Dr. Joe needs a vacation? We'll give it just another minute. All right, we're kind of split on this one. I see this is information kind of hidden above the MDM table if you're looking at that. So the answer to this one is B. Ordering a test may include those considered but not selected after shared decision making. So in Sally's case, she really wanted to have an MRI done, but Dr. Joe had conversations with her about why it's not medically necessary to do such a test at this time. So long as that information is documented, Dr. Joe can count this under category 1 for test ordered. It accounts for the work and the thought process required during that visit, even though the end result was that the test was not ordered. I have a little bit of a lag with my slides. Here we go. Okay, for our last question, for an interactive exchange to count as discussion of management, the external physician must be which of the following? Is it A, in a different city or state? B, a specialist who does not accept the patient's insurance? C, not in the same group practice or of a different specialty? Or D, a physician who has never treated the patient before? All right, the answer for this one is C, not in the same group or of a different specialty. So for moderate or extensive data, we have discussion of management or test interpretation in category 3. The discussion must be with an external physician, meaning a physician outside the practice or of a different specialty. Again, it must be direct and not through intermediaries, such as messages passed along through clinical staff or office staff. Discussion of management does not include sending chart notes or written exchanges within the progress notes. The discussion does not need to be on the date of the encounter, and it's counted only once, and only when it's used in the decision making for the encounter. It does not need to be done in person, so it could be, for example, a phone call or an email. It must be initiated and completed within a relatively short period of time, meaning within a day or two. That discussion needs to be documented. What was discussed? Who was the discussion with? And what was the outcome of that discussion? Here we have some additional resources for evaluation and management services. First is a page on our website with some high-level information on evaluation and management services. This one's really a great page if you're new to medical decision making. Next is a page on documentation for an E&M service under TPE review, which includes a few tips about signatures, as well as some links to additional CMS resources. And then the last one listed here includes the CERT errors for evaluation and management services that I spoke about earlier in the presentation. All right, I do see we are almost at the top of the hour. Out of respect for everyone's time, we won't get into the chat questions today, but please don't worry. I will send out an email to all who attended today with answers to any unanswered chat questions. If you do think of any additional questions, you have 7 days from today to submit them, and you'll send those to our education mailbox. And make sure to include the title of this webinar, Catching the MDM Wave, Data Review, Interactive Q&A in the subject line, or you could just shorten that up to MDM Data Element or something like that, so they make sure those emails come to Leanne and I. Please keep in mind that we are not able to access any claims history, so you will want to contact customer service for any claims related questions. In a few minutes, you will receive an email to thank you for attending, and you don't want to delete this one without reading it. The email contains your certificate of achievement. It will have your name and contact hours if you need to turn that in for credit towards continuing education units. Now, if you do not receive the email, there are a few things that could have happened. First, you may want to check your spam or junk folder. Also, be sure to add messenger@webex.com to your safe sender list so that any future messages will show up in your inbox. Also, if you joined by phone only, you would not have received this email, as there's not a way for us to capture your email systematically from the attendance record. But no need to worry. If you did join by phone, you are able to email us and make sure you include the phone number you joined with, and you can request your certificate of attendance. And Leanne will be adding that email address to the chat. Lastly, please take a few minutes to complete the survey. Tell us what you liked today, what we can do better, and you can suggest topics for future education. You have a few different options to take the survey. You can use the link in the chat, or when you exit today, you'll be prompted to go to an external site, and that external site is the CMS Qualtrics page. And you'll have a prompt that'll look kind of like this picture we have shown here with a little yellow triangle. And we included that image on the top right of this slide so that you know this is safe. It's not malware or anything like that. Now, for those listening through our website or through YouTube, you also have the same opportunity to provide feedback. You will have a survey card at the end of the presentation, and the link is also available if you scroll down to the bottom of the description. All right, that concludes our webinar for today. Thank you all so much for participating in the activity. We have lots of fun with those. On behalf of myself, Leanne, and all of Provider Outreach and Education, we thank you for taking the time to join us. We look forward to your survey feedback And we hope to see you again next month for our risk series. Everyone have a wonderful afternoon. You may now disconnect.